We will go ahead and get started. We have our first presenter who is joining us again. He had such a overwhelming response of positivity from our November conference. We wanted to bring him back, and that is Dr. Jeffrey Donowitz, who will be giving us a COVID-19 update.
Great. Thank you so much, Carol, and thank you all for joining us this morning. And it was such a pleasure to talk to you back in November. In terms of the disease of COVID, it's still there, obviously, not much has changed. But the one big thing that's changed is help has arrived. And we need to talk about vaccines. There's a lot of mixed messages. There's a lot of misinformation on social media and other places. And so I'm going to spend about half an hour with you going through some slides and then really want to get your questions answered. So if you have questions, I tried to incorporate as many that were submitted ahead of time into the presentation. But if there's something I didn't answer or something that I'm not going to answer because it's not vaccine related, throw it in the chat and we'll have some time at the end, or the Q&A, I guess, and we'll have some time at the end to go through those. So again, sorry, my name's Jeff Donowitz. I'm a pediatric infectious disease professor at the Children's Hospital of Richmond. Financial disclosures, I do have some grant money to study COVID. So I always tell everybody I am a part of my salary is paid by this grant from the NSF, looking at the human microbiome's effect on this virus. So the first thing about vaccines that is just a tenet of all things medicine is they only work if you take them. And we have a problem. So this data was taken about, almost 6 weeks ago or so, right before the vaccines were available at our medical center. And this is nationwide data from hospitals. And so you can see here on the right, it's about 100 primary care physicians, about 200 registered nurses, and then 70 medical specialists, so subspecialists like myself. And you can see here that 31% of the respondents said, yeah, I'll take the vaccine as soon as it's available. We have 54% that say, not in the first wave. I don't want to be first. And then 15% overall say, never getting it. So when we look at why people are hesitant about this vaccine, safety floats way to the top of the list. So everybody's concerned that this may not be safe. And if you notice, the number that are concerned it may not be safe is approaching the number that won't get it. So you have to say the first wave, the people who don't want it in the first wave feel it may not be safe. And even some people who are willing to get it still are going in to get it nervous about getting it because they're not sure that they're getting something in their arm that's safe. And we've seen that in our vaccine clinics. People come in very hesitant. People are worried it may not be effective. And then a big one, especially out of the people who say, I'll wait, they're worried politics has played a role in this development. And so that makes them nervous. And then there's some other reasons as well. They don't trust big pharma. They think COVID-19 is overhyped. With the amount of dead in the country, I'm not sure how that is even 3% there, but it is. Moral problems with vaccines and other things like that. So again, just another way of looking at very similar data, it's about a third of the people that think this will be safe, that have a neutral opinion or they disagree. And this similar for effective, 74% of people, I think this is the big one on this slide, worry that this was rushed. And the answer is, it was absolutely rushed, 100% rushed. We've never brought a vaccine to market so quickly. What I'm going to talk about today is how was it rushed and did that compromise safety? Because I don't feel it did. So really, this is the bulk of the summary here. 76% of people are uncomfortable with this vaccine as of 6 weeks ago. And these are medical providers. So in order to understand vaccines, we got to go way back. And I know that for a lot of you, this may be review, but I think it's worth talking about anyway. In in order to make a vaccine, you need to make antibodies. So antibodies, which are these little Y-shaped things on your screen, they're specific to the pathogen. So the one that sticks to influenza won't stick to the COVID virus and vice versa. But they float through the body till they find that bacteria, that virus, and they mark it. And they mark it so that immune cells know to kill it. They sort of say mark it for death. And they're a very powerful arm of the immune system. They're much better at preventing infection. So if you have these floating around in your blood before you see the virus, they're much better at that than giving them to you while you're very sick. There are really 5 types of vaccines. So there's live attenuated. This is where we take a live virus. It's still alive. We just genetically cripple it in some way so it can't make you very sick. And we inject that into you. There's inactivated, where it's still the whole virus, the entire thing. We just like heat kill it, and then it's dead. And so you just take dead viruses and put them into you. And then there's the subunit and recombinant and polysaccharide vaccine, all sort of versions on a theme there, where we don't even give you the whole thing. We just give you a part. We just give you some part, some protein that we think, or polysaccharide that will trigger immunity, that will prevent, the innate immunity that's triggered by that one part protects you from the virus. And that's what we leveraged with these new mRNA vaccines, although we did it a little differently. There's certain vaccines that are toxoid vaccines that are a little different. Some bacteria make toxin, and it's the toxin that makes you sick. And so we just target the toxin. And then these mRNA vaccines, which are the new kids on the block. So in order to understand mRNA vaccines and why they're safe, we got to go even further back into our biology classes. So you have the DNA in the nucleus, which is here. And the nucleus is this protected shell. I think it's really important that this vaccine never reaches this nucleus. When DNA gets transcribed into RNA, so it's a mirroring fragment, but it's just a fragment of the gene that your body needs. So if your body's trying to make insulin, it just copies that little portion of the DNA code, and that little copy floats out into the cytoplasm here. And this is where we're hijacking this machinery to make this vaccine. So RNA is in the cytoplasm, and then your body takes this template of A, C's, G's, and T's, and it turns that into a protein, whatever protein you're trying to make. And it's really important to realize that these RNAs, they're degraded very quickly. So our body uses them, and then it breaks them down and recycles the pieces to make another one. The DNA never gets broken down. It's protected. It stays there. So how did we leverage that machinery to make a vaccine? So the idea is the first thing we did was we isolated that the part of the virus that we needed to make, that we needed these cells to make, was this spike protein, which you see here, and in all the cartoons, the virus has this spike on the outside. And this is, we're going to get back to this spike protein in a minute, because that helped us. We knew that before SARS-CoV-2 ever hit, that was the piece we needed to make. So then we needed to make the genetic code that encodes for that spike protein, just the spike protein. We knew that out of China before the vaccine ever hit the US. There were some great researchers out of China who got us that. The next thing is we had to figure out some way to get this into the body. I told you these RNAs are degraded very quickly. We had some way to protect it till it could get in your cell. And that was this lipid coating. And so we put it into you. The lipid coating merges with your cell membrane. It drops the RNA into your cytoplasm, and then your body's machinery, it's translating mRNA into proteins all the time. This mRNA from the vaccine gets into that machinery, and your body makes just the spikes, not the whole virus, just these little spikes. And these little spikes, they go to the cell membrane, and your body goes, oh, what's that? That's not part of me. And it makes antibodies to those. And that's how this vaccine works. So it's similar to the subunit vaccines, but instead of just giving you spikes, which doesn't work real well in this virus, we give you this mRNA, your body makes the spikes, And then the immunity recognizes them really well, the immune system. So people say, was this rushed? That's a major fear. So it was absolutely rushed. It usually takes a decade or more to bring a vaccine to market. There were a couple things that accelerated this process in this situation. In the arrows up top, in the yellow boxes, that's normal. That's the normal vaccine process. The preclinical, identifying what part of this virus or bacteria we can use to get your body to make protective immunity, finding the spike in this case, often takes years. It's all done in the lab. It has nothing to do with safety. It's just trying to find whatever piece of this bug that will trigger your immune system is. With this, we knew it before SARS-CoV-2 was ever a thing. That research started with SARS-1 in 2003 and MERS in 2012. You know, these were, like I told you last time I was here in November, there have been 4 viral crossover events that caused pandemics in humans in this century: SARS, MERS, H1N1 influenza, and this COVID virus. 3 out of 4 of those were coronaviruses. We were studying this already. We knew there were coronaviruses that were going to threaten humanity again. And we knew it was that spike that was the key. So all of that usually takes years and years and years, we had on the shelf waiting to go. And the minute we had that RNA sequence, we were off to the races with this one. The other thing that, of course, helped was anybody who had anything that could possibly help, like that lipid layer, that lipid envelope, that was sitting on the shelf, but hadn't been deployed because there wasn't funding for it. And so if you had any idea that was possibly going to help here, the government threw millions and millions of dollars at you, which always helps speed things up. Phase 1, this is really just for safety. And this was done identical as it's been done to all other vaccine and drug trials. This wasn't changed at all. When you get to phase 2, which the more subjects you get, the more data you get on safety and efficacy and dosing. So in the phase 2 trials, the way this used to work was you'd do your phase 2 trial, you'd shut everything down, your site would close, you'd submit your data to the FDA, they'd look at it over a number of months, and they'd get back to you and say, okay, data looks good, you can do a phase 3, you rehire coordinators, you find new sites maybe, and you open your phase 3. And all that was very lengthy. Even pre-COVID, in the last couple of years, there's been a move to combine these because it's wasteful. So the idea is the FDA gets quicker at their review, and you sort of pause all that research machinery, but you don't shut it completely down. Your site is the same coordinators enrolling. You just pause. FDA does their thing. They get back to you. They say you can move to phase 3, and you pick up right where you left off. So just in terms of that logistics, it's much quicker. So that's what we did here. And we'd done that previously, but this was the first time we really rolled it out. The other thing is I'm going to show you that really sped this along is for the phase 3 trials, you predetermine the number of cases you need to be statistically significant. You say, we're going to run this thing until we get 200 cases of COVID. And if it's a rare disease, that may take you a couple of years. In something like COVID in the end of 2020, that took 6 weeks, a month, 2 months, somewhere in there, because there was so much disease. And then the phase 4 is still going on. This is post-market. This is after it's out in the general public. We are still studying these things, and I think that's important to note. So the next couple slides are these are the actual data out of the trials. And so, you know, this is the Pfizer trial. You can see the Pfizer and Moderna are very similar. So it's about 43,000 volunteers, 1-to-1 got the placebo, got the vaccine. Researchers were blinded. They didn't know who got what. And like I told you, the N number was 170 COVID cases, with at least 10 of them being severe when they would stop the trial. Really important, the way both of these trials worked is you got either the vaccine or the placebo, and you checked in with Pfizer every day. And if you said you had any symptom, then they tested you. But asymptomatic people were not tested. And that's really important. So when they got to 170 cases, they unblinded it. And what they found was 162 cases were in the placebo group, 8 were in the vaccine group, 9 of the hospitalized patients were in the placebo group, and only 1 of the severe cases, these hospitalized patients, were in the vaccine arm. So this graph's a little complicated, but basically what I want to show you is the blue line is the placebo group. And as you get more and more cases in the group, the line goes up. And the red line is the vaccine arm. This is taken right out of the application to the FDA, which you can see here. And this little section here is blown up. You can see right around day 11, day 12, these lines start to break off from each other. So there's some protection. Even day 11 after the first dose. And this is after the first dose. So the Moderna trial, very similar, about 30,418 volunteers, equally broken up into 2 groups, blinded researchers. 196 was the magic number with 30 severe cases. Again, all of that is set before you ever start enrolling. That's based on some statistics that you need in the power calculations. 185 in the placebo group and only 11 in the vaccine group. And all 30 severe cases in this trial were in the placebo group. And again, these 2 arrows, first dose, second dose. For the Moderna, you still start to see these lines separate, sometime around 10 to 14 days. I think if you notice the slope of this line after the second dose really starts to go up. So if you weren't protected by here and you got your second dose, you're really starting to see protection there. So these are the adverse effects. People are really worried about the adverse effects of this because people say it's really bad. To be honest, it's not that much worse in terms of number than some of the other vaccines that we give all the time. The ones that really stand out are the shingles vaccine gives people some reaction. The rabies vaccine gives people tons of reaction. And the MMR is the other very antigenically powerful one. Remember, this is the things we feel, the aches and pains and feel bads, that's your body's immune system getting angry. And that's what we want here. So the blue line here is the first vaccine versus the first placebo in red. Green is the second dose of the vaccine, and purple is the second dose of the placebo. So when it comes to local reactions, some pain at the site, some redness, certainly much more, about 80% of people will get that, and much more than the placebo. Really, nobody gets fever except, it was about 19% after the second dose of the vaccine will get fever. Again, higher incidence of headache after the second dose, fatigue after the second dose. And you'll notice that these numbers are up near 60%. That's pretty consistent with the MMR and the rabies vaccines. So not out of the norm of what we do for vaccines. Myalgias, a little bit of nausea and vomiting, chills, again, very similar pattern. With somewhere in the 10 to 40% range for the first dose and higher than that in the second dose. I think it's notable that for medically attended adverse effects, so where they saw a doctor, even if it was outpatient, was identical across all groups. And for serious or severe adverse events was identical across all groups and less than 0.5%. It was about 0.5% in all groups, but even in the placebo group, it was about 0.5%, which is really reflective of the background rate of something bad happening to you any 30 days type of thing. So in order to talk about this vaccine, I think it's really important to talk about what we know and what we don't know, because there are some things we don't know. So is it effective? We know it's effective. We know that it protects people 94% from getting COVID, 95% from getting COVID, and almost 100% from getting severe COVID. So even if you do get the virus, and even if you do get sick, you're not going to land on a ventilator. We know that efficacy was consistent across all ages, genders, and race ethnicity groups, which is really important. And that's true for both vaccines. The mRNA vaccines are safe, and we have about 3 months of data. I should change this slide because it's probably longer now because the first people enrolled in the trial are obviously, it's longer than 3 months. And people ask me all the time, is that enough? What about the long-term side effects? The fact of the matter is that is the long-term side effects. 99% of vaccine adverse reactions occur in the first 30 days. And this includes things like the immune-mediated reaction. So we know that a very small group of kids that get the MMR are going to have immune thrombocytopenia. So your body attacks the platelets in the blood. It's very rare, but a known thing with the MMR. That happens within 30 days. All of the immune-mediated side effects of vaccines we've ever documented happen as your body is responding to that vaccine. You don't get a vaccine side effect 6, 8, 10 months down the line. That's just not the way it works. Your immune system has responded and is back down by that point. We know side effects are more frequent after the second dose, and we know that severe side effects are rare and not different than placebo. So what don't we know? What are the lingering questions? So number one is, how often will we need to be revaccinated? We're still monitoring all the people in the trial, but we don't know how long that immunity protects. Are we going to need a booster every year? Are we going to need a booster every 5 years like tetanus, or 10 years like tetanus? So that question is still out there. At least 6 months is what the data seems to show, but 6 months and counting is what we would say. Safety and efficacy in children and pregnant women. And I know that there were a lot of questions around this that came in before. So pregnant women, I'll take first. ACOG, the American College of Obstetricians and Gynecologists, has recommended that this vaccine be offered to pregnant and breastfeeding women as it would for non-pregnant and breastfeeding women. The UK National Health System has recommended against giving the vaccine. So what's the discrepancy there? The NHS in the UK didn't say anything about whether they thought it would be effective or safe in women. They just said, we don't have data in pregnant women, therefore no data, no recommendation. ACOG took a different approach. There are 2 vaccines that are contraindicated in pregnant women. Both of them are live virus vaccines of viruses that are known to cause birth defects if you get the real virus. So that's rubella, and that's the chickenpox virus. SARS is dangerous in pregnant women. Pregnant women are 3 times more likely to be admitted to the ICU or need a ventilator than non-pregnant women when matched for age and other things. But it doesn't harm the fetus. It doesn't cause birth defects. And this is also not a live virus. This is just a little piece of a virus. So for those reasons, ACOG said there's really no scientific reason to think that this would hurt a pregnant woman or the baby. Also, the DART data, which is DART is a developmental data in rats, which is a pretty good model of birth defects, where we give the vaccine to rats before they get pregnant, while they're gestating, and while they're nursing. None of that showed any effect in the offspring of those rats. No birth defects whatsoever. In terms of children, the Pfizer vaccine is actually licensed down to 16 years of age. They included that in the original trial, but neither vaccine is currently offered to children below 16. And those trials are being planned. We are working on getting one of them at CHOR, but we haven't heard from the company yet whether we've been selected as a site. Bill Cook is leading that effort from the Pediatric Infectious Disease Group. But these trials are being planned. There's still plenty of COVID in the community. So for all the reasons that the phase 3 trials were expedient with the adults, we're hopeful they'll be expedient in children once they're enrolling. Extremely rare adverse effects. So that's why we have those phase 4 where we're still studying. If it's 1 in a million, 1 in 10 million, we may start to see, repeated cases of things. And this is where we've seen allergic reactions that are about somewhere in the neighborhood of 1 in 1.5 million people will get a severe allergic reaction. All of those people of note are known to have severe allergies. All those people walked with EpiPens. If you don't walk with an EpiPen normally, you're not going to be one of those people that gets a severe allergy. If you do walk with an EpiPen, that doesn't guarantee you'll get a severe allergy. which is why we still recommend you get the vaccine. We just recommend you sit there for 30 minutes and let us watch you. At this point, if you are worried about being the first, there's currently 46 million doses have been given in the US. It's about 11% of the US population. You're not the first. And so we're seeing these massive numbers without seeing rare 1 in a million type side effects. The other thing is because the studies only monitored people who got symptoms, we still don't know whether getting this vaccine prevents you from getting asymptomatic disease. Is it just that we prevented you from getting symptoms, but you still get it? It's in your nose a little bit. You shed it, which has big implications for herd immunity. And then you get over it and you get rid of it and you never knew you had it. This is why, even if you got the vaccine, it's not a green light to go out into the community and have a party because everybody around you hasn't gotten the vaccine and you still may be shedding it. You have to keep your mask on because you still may be shedding it, and masks are, prevent you from giving it to other people. So until everybody is vaccinated, it really shouldn't change your behaviors at all because we don't know whether you can still spread it, once you have the vaccine. I will say that chances are, and this is just my opinion based on the science I know, that it does decrease your spreading somewhat, but probably not 100% in 100% of people. So people ask me all the time, would I take it? Would I let my family take it? I absolutely took it. I was trying to be first in line. I wasn't first, but as soon as it was available to me, I absolutely took it. And that's my wife there on the other side. And she absolutely took it. And people ask me about pregnant women. She was 9 weeks pregnant when she got her first shot. We knew she was pregnant. We did the literature searches. I read everything there was to read about pregnant women in this vaccine. And both of us together were both physicians, and we made the decision that she should get it. So the answer is yes, 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 and yes. And with that, I will stop my screen share here and take questions.
Okay, so we do have a couple of questions coming in, and I'll slowly fire them at you. Do they recommend one vaccine over the other for people with severe allergies?
No. So the part of this vaccine that is probably triggering the allergy is something called polyethylene glycol, which is basically the same thing that's in Miralax. But it's also used in vaccines. That same molecule is used in vaccines as part of the carrier. So that it's part of that liquid that carries this molecule in a lipid, this lipid vaccine, the active ingredient to you. And it's probably that polyethylene glycol that's triggering that reaction. Both of them have it. So for people with severe allergy, one's not going to be better than the other. And like I said, it's the minority of people that have had severe allergies in their history that even have a reaction to this vaccine. Not a reason not to get it, but is a reason to sit there and make sure that you're monitored, type thing, after the shot.
Is there a place that if people feel that they do have a severe reaction that they should be reporting those to?
So you should tell the vaccinating site. So all sites know that this is a thing. They've had education on that, and they've been, they should be trained on how to respond. If you are somebody that has a severe reaction, bring your EpiPen, obviously. But if you sit there for 30 minutes after you get your vaccine, the site should have a place designated for you to hang out. And if you start to feel any of your allergic symptoms, you just need to be very vocal about that and say, hey, I'm starting to feel something, and then let the wheels turn to go ahead and get you epinephrine and all the things that we would do to protect you. And we've been doing that across the country as this has been rolled out. We've seen a handful of those severe reactions, just a handful. But nobody's died of them because we, like any severe allergic reaction, if you jump on it quickly, you can really abrogate the severity. So if you're watching for it, the chance it hurts you is much less.
Right. So this question, I think we could probably only speak for ourselves here at VCU Health. But it says, of those refusing the vaccine, and I hate using the word refusing, I think they're probably just choosing not to get it right now. Are we seeing that that is more of a physician over nurse breakdown, or is it more ancillary staff versus medical staff?
Yeah, so in that study of healthcare providers, it was almost equal across the board between the different groups, and that includes physicians, subspecialty physicians, and nurses. It was very, and ancillary staff. It's really this idea of vaccine hesitancy and being hesitant for this vaccine. Clearly isn't related to your training or your education. This is sort of the same breakdown across all groups, and studies in the community have showed that as well. That it doesn't seem very tied to your education level. There is increased hesitancy in African American and Latinx populations. Some of that is thought to be due to very real history in terms of experimenting on certain groups, the Tuskegee studies and those things like that is real trauma.
Right.
And so there is increased hesitancy in those groups, and I get it. But that's why we need to build that trust and do that with real data and education.
The next question is, one individual has received multiple questions from women childbearing ages about evidence on increased risk of infertility or miscarriages. Have you seen any?
Is a huge social media issue. So that's one of the biggest fallacies on social media today, is that this vaccine causes miscarriage. That stemmed from one amateur geneticist, very amateur, who decided that there was a portion of the spike protein, that sequence of A's, G's, and T's, that mRNA, that overlapped with a protein that's in the placenta. The overlap is about 4 base pairs, which is genetically meaningless. So if we tried to overlap just a string of 4 A's, G's, and T's, if we tried to overlap that, we'd find overlaps all across the body, because these things are hundreds and thousands of A's and G's, T's long. And so an overlap of 4 is absolutely meaningless. That does not mean that this antibody is going to recognize that 4. It's a drop in the bucket. But some amateur found that and said, oh my God, it's going to cause you to attack the placenta. And that just hasn't been true. So women who get the actual virus and make these antibodies from the actual virus, we're not seeing higher rates of miscarriage. And we're not seeing infertility in those women, although it hasn't been long enough. But we're seeing no effect on that machinery in women, uterus, ovaries, those type of things. So there's really no scientific basis for that whatsoever, and is just a viral fallacy.
Perfect. Thank you for getting that, dispelling that myth, rumor, false news to at least 350 plus people this morning.
Spread it to your friends.
Yes, we're all friends here. How long before we will know if we need the vaccine on a yearly basis? In your professional opinion, how much more research would be needed?
Yeah, so this is simply time, right? So we enrolled these basically 70,000 people between the 2 phase 3s. Half got the vaccine, and we're watching them. We're still watching them, and so every day that goes by, we're getting more data. But until I tell you, until they've had it for a year, and we've seen if the vaccine arm is starting to get more virus, nobody's going to feel safe telling you that it's not a year. So it's literally, we are watching those people, and every day that goes by is another day we tick that they're safe. So it may be a while. At this point, we're still focused on using our vaccine stores on the first round, getting everybody a vaccine. But we're already working with drug companies. When I say we, I mean the government and the national level, to make sure that we have supply if we need booster doses in the future.
So now at this point, do we have any idea for those that may have gotten the vaccine earlier, how long they are still showing antibodies? I mean, do we have people at this point that are still showing 6 months out?
We do. Yep.
Antibodies? Okay.
So the data that I've seen, and this is not published or peer reviewed, but is on some webinars out of the CDC and things like that. Everybody is at this point pretty confident that we've got minimum 6 months protection. We'll see how far it goes. That's where we are now, is about 6 months. Okay. And so we know you're protected for at least that. When people get this virus, they make wildly different amounts of antibodies. So some people make almost none. This is the virus, not the vaccine, the virus. So some people make almost none. Some people make a ton. And we know that the vaccine puts people in that ton category. So you respond to the vaccine like the most severe response to the virus itself, which is good, because the more you make, the better you're going to be protected over the long run. If you didn't make very much to start, you're probably not going to be very, protected for any length of time, type thing.
And I think that's where some of the misconfusion comes with persons who have had COVID and believe that they need to wait 90 days to get the vaccine. What, in your professional opinion, what would be your thoughts on that? Because I think that a lot of the schools, even my own children's school, some of the teachers are saying, well, I had COVID, so I don't need to get the vaccine.
Yeah, so the original recommendation, which has since been discarded by the CDC, was that you wait 3 months after your COVID before you get the vaccine. And that recommendation was probably made, I wasn't at the table, obviously, but was probably made to actually free up some vaccine for other people. You can get COVID a second time, but nobody gets it within 3 months. Even the people who make very low levels of antibodies seem to be protected against reinfection for at least 3 months. So the idea was, if you just had COVID, you can probably, and even in the first recommendation, it wasn't a hard recommendation. It was like, should probably wait 3 months. And so that's where that came from, is you probably don't need it in those 90 days, in those 3 months, because you have some natural protection. That being said, we know that some people don't respond well to the virus, but they will respond well to the vaccine. So at this point, we've said, listen, if you have COVID, don't get the vaccine while you still have symptoms. It's probably reasonable to wait a couple weeks. In my professional opinion, when a family member asked me this exact question, I told him, listen, I would probably wait. I would wait till I was asymptomatic, and then I would wait 2 to 4 weeks after, just till I'm done with the actual infection, and then I would get my vaccines. And the idea is you don't know how much antibody you made to the actual virus.
Right.
But you do know that you'll respond well to the vaccine. So go ahead and get the vaccine.
Now, I know that there's been a lot of information recently around the second dose. And do you take Tylenol before? Do you not take it after? All of that. So what would be, again, in your professional opinion, about taking Tylenol before getting the vaccine? And if you do, there's also confusion around, does it alter the immune response?
Yeah, so I have not seen convincing data either way, that it does or it doesn't. But remember, back to your childhood vaccines, right? So what do we tell parents after we give them the primary series? We say your kid is we should be saying, Your kid is may get a fever, may get fussy, and if they do, give them a little Tylenol and they'll feel better. There's not a good reason to think that Tylenol is going to abrogate this immune response to the level that is going to matter. So I can tell you, after my first dose, I had a sore arm. After my second dose, I had, just some sort of generalized aches all over, jointy stuff, and I took Tylenol.
And I'll say I actually had more aching site pain following the first vaccine. And then the second vaccine, I had nothing. And I think I was more anxious because I had been told that I may feel awful and I'm going to have this and I'm going to have that. And so it was more here than in here. So just try to remember, you're telling yourself that everyone is different. And I was extremely surprised that I had no reaction following the second dose. Now, this question is, does the vaccine offer protection from other coronaviruses? Are there special considerations, recommendations for those with autoimmune disorders or immune deficiency?
Okay, so a couple of things there. So let me take the easy one: autoimmune disorders or immunodeficiencies. So autoimmune disorders, we're not worried about. Changes nothing. Immunodeficiencies, and this is where autoimmune disorders, if you are taking a medicine that makes you immunodeficient, then you fall into the immunodeficient category. Your chance of having an adverse reaction or something like that isn't increased at all. The risk is that you don't respond as well to the vaccine. So we don't know, and this depends on what type of immunosuppression you have. So immunosuppression is not yes or no. It's a large scale of gray. So maybe you're on a little bit of immunosuppression with some steroid, or maybe you're a bone marrow transplant patient. We've wiped out your entire immune system. So it's a scale. But depending where you fall on that scale, you may not make great antibody to this vaccine. You may not respond as well. So certainly get it, because any response is going to help you. But just know that you still need to be protecting yourself, in terms of masks and washing hands and being careful and avoiding social situations until this virus is, gone from our community. So that's the risk with immunocompromised patients and vaccines, is you may not mount the immune response that you'd like. In terms of the other side of that question, protecting against coronaviruses and other coronaviruses, this vaccine does not protect against other coronaviruses. So it won't protect you against SARS-1. It won't protect you against the coronaviruses that cause the common cold. The NIH is currently putting lots of money toward developing an all coronavirus vaccine. That call went out a couple months ago to say, if anybody's got an idea, we will pay you to develop it. I think we all know that coronaviruses are a threat, and we'd love a vaccine that says, hey, no matter what the next coronavirus to jump out of a bat is, we're going to be protected against it. So we're working on that.
Good to know.
The other question that gets raised all the time is these variants. And we've heard about the South Africa variant, and we've heard about the Brazilian variant, and we've heard that the vaccine may not be as effective against those variants. And that may be true. So if you take the antibody, the plasma from somebody who recovered from the virus, and in a petri dish, if you put those antibodies from that person into that petri dish along with the virus, it should neutralize it. It should kill it. It works about 10% less on these variants in the petri dish. The question is what does that mean for me and my body? And the answer is we don't know. Is 10% less enough that it doesn't work at all and you could get sick? Probably not. But that data is still out. Does it mean that you may get a mild infection, but you're not going to get a severe ICU level infection? That could be, so we still don't know is the answer. My professional guess, and again, this is just me and my guess, and take that for what you will, is we will probably see more mild symptomatic infection from these variants, but I don't think those patients who've been vaccinated and get the variants, at least the variants we've identified up to this point, are going to be in the ICU. But time will tell on that. But you know, certainly did not, it didn't stop all neutralization. It was just 10% less. So it still neutralized 90%.
And has there been any, so we have one question about, does taking Benadryl prior to the vaccine help with any known allergies?
Yeah, so if you're gonna, you know, we recommend that anytime, at least in the hospital, that we know we're giving something that somebody may respond to, you can take Benadryl ahead of time. If you are a severely allergic person, you know, you can decide to do that and take Benadryl before you get your shot. It's not recommended at this point because, you know, even in the group that carries an EpiPen, reactions to this vaccine are so rare that we're not recommending that everybody take Benadryl ahead of time, type thing.
Perfect. Okay, let's see. Does the Red Cross share its data on antibody information? I received first dose on 12/26 and second dose on 1/16. Gave blood, which is routine for me, on 1/19, and my blood work showed antibody response. So I guess she's just saying, are they sharing that information with the CDC and other information gathering organizations?
Yeah, I'm not sure. I will say that I was very involved with the convalescent plasma program, or you know, in this virus, and the Red Cross was amazingly you know, free with any data that they had. So yeah, I assume that the Red Cross is sharing that data. I don't know that to be true, but you know, one of the things that has just been amazing from a science perspective about this whole pandemic is any sort of hoarding data for personal gain, sitting on data, you know, competition among scientists, you know, wanting to be the first to publish something. That has gone out the window. I have never seen such collaboration across government agencies, private entities, academic scientists like myself. You know, everybody just sort of turned toward this threat. So I'm sure if that data, you know, is available, it's being shared.
Perfect. So Tracy, Joanna, this might be a question for you. It looks as if we have some persons with concern for getting their second dose. I know that a fair amount of the teachers and school faculty in the central region, I can only speak to, had opportunities to go and sign up and get their first dose. What is the process or plan for guaranteeing that they'll be able to get their second dose as well?
So, Carol, this is Tracy White, and good morning, everybody. Joanna, you don't need to mute yourself. So each school division is working with their local health departments and/or hospitals to facilitate the vaccine within their school community. You know, we are a Commonwealth, and although our local health departments are taking the lead on this, there has been some, as Dr. Donowitz was saying, a wonderful sharing. I know that hospitals have reached out to school divisions and have folded in school nurses as part of their process. So it's going to be variable. I know I can just share at the Department of Education, you know, we are also in the same position where we have people that interface with our schools on a regular basis and have direct contact. And so we are also going through that process of registration and have been in contact with a lead person. So, you know, they're very good about follow-up in order to get that second vaccine to the people that received their first vaccines. So, and a lot of it's involved. Those are questions asked in the registration process. So I feel quite confident that people will get that second vaccine in time. Joanna, do you have anything? else to add to that?
Yes, Tracy. Thank you so much. Good morning, everyone. Real quick, the Department of Health, to add a little bit to Tracy's, is to keep in mind that there is a new vaccine website, so you
Right.
guys can keep track of it. It's the Department of Health. And also, they have set up a call center that's for all of Virginia. So you can call in and check on your status and check any updates. But like Tracy said, the record keeping is excellent. As anyone knows who's had the first dose, you register, they get email, phone numbers, and there is constant follow-up. So as far as the second vaccine, don't worry. You'll be well taken care of, and you can keep checking the website itself, and also call in the call center if you have concerns.
And can I just add too that the call center and general registration site, it doesn't matter where you live in the state. So instead of going through your local health department, you go to one unified call center and call in, and they will make that contact for you. Maybe we can put that in the chat, Joanna, that number, that information.
Absolutely.
I know, ladies, that there was some questions prior to that around the distancing in the classroom and in relation to room spacing. Is a lot of that, I'm going to make the assumption, but you can correct me if I'm wrong, being determined by the specific localities. I think that the direction is being provided by VDH and VDOE, but the interpretation of that is definitely happening at the locality level.
Well, the CDC just came out with new guidance on Friday, and they're still recommending 6 feet with a mask. And that's a little, I'm not sure what AAP is going to come up with, the American Academy of Pediatrics, if they're going to still say 3 feet with a mask. But we, as with many things, this was just announced. And so there is a plan, the Virginia Learns program, which is something that the Department of Education is putting together, and will work along with the health department to revise our phase guidance that we currently have, and to comply. And as Joanna is always fond of saying, that when CDC sends information or provides guidelines, VDH always doesn't just rubber stamp it. They review it, they endorse it, so that it is specific for Virginia. So between the health department and the Department of Education, we will be able to provide schools with that information. In fact, there is a superintendent's meeting tomorrow with Dr. Lane for all school division superintendents tomorrow morning to talk about this. And we're going to keep them in the loop because we want to get kids back in school, but not until it's safe to do so. And we are here to help and support our local school divisions in whatever area that they need. And it's the same with the health department.
I know there's been some question around mandating the vaccine. I think it's just kind of,
it's not going to happen.
Okay.
There's been some legislative,
right.
Yeah, there's been some attempts in the General Assembly to do that thus far. It still is, it's not mandatory. You cannot be forced to get it, nor can you be forced to disclose that you've had it. So this is personally identifiable information. And so it is totally voluntary to report any of this to your school. It's just like we wouldn't ask a parent, confidential information about, parents don't have to reveal to us as a school that their child has X condition if they don't want to. Now, we would hope that they would want to, so we could best support their child in the school setting, but there's nothing that says they have to do that.
At this time, I think the current, like you were saying, the AAP guideline is 3. They are comfortable with the recommendation of 3 feet. It does look like some of our attendees are concerned with that distance. Is there any data that shows, or anything that you ladies can speak to about schools that are in person and are following those guidelines, and if they're seeing success with that or overwhelming cases? I mean, I could speak personally, but I don't, because my children are in school. But if you ladies have a professional perspective, I'm sure that's what they would more like to hear.
Carol, as of right now, and we want to stress exactly what Tracy said earlier, the CDC is, they've never wavered on their 6 feet distance. So we want to keep that in mind, because it's 6 feet with a mask, and a close contact is considered any contact that someone is closer than 6 feet for a cumulative time of 15 minutes. So we really need to think about that when we're looking at reopening plans and in-person learning. The AAP has previously said 3 feet with a mask, and that is possible if you can't, but to the greatest extent, you need to do the 6 feet with a mask. And that may take rearranging the classrooms. That may take, instead of being in one class, that may be spreading students out and using the library as a classroom, or, or the cafeteria as a classroom. So we do need to kind of think a little bit out of the box and focus on our efforts being 6 feet of distance. So, and that's kind of what the CDC has said all along, but it has come out again Friday stressing that. The Virginia Department of Health is right there with them as far as 6 feet. So just, that's kind of our focus right now, is to keep in mind that a close contact is closer than 6 feet with a mask.
And Carol, I just want to add to the practical aspect of this is in local schools, is that parents will be making that decision whether their children will be returning in person to the classroom. And there's going to be a percentage that will not for the duration of the school year. This is ultimately their decision. And so I think that's part of the consideration. I think there's going to be space to accommodate the kids that will be returning to school in person. We're going to, I don't know what the percentage is, but I doubt that I would guess that we were not going to have full in-school classes initially for the remainder of the school year. And so I don't want people, and I'm sure teachers, they're thinking ahead. And as school nurses, they're going to be coming to us, how can we do this? How can we do this? And, I just don't want people to get ahead of themselves. You do the best you can in a situation. You provide the information that we have that's most up to date. And, parents will make that decision, and the schools will just do their best to respond accordingly to spacing needs.
And I think what I found, even as a parent, is right now we just all need to practice some grace and understand that we're all learning, and that our school districts, our medical providers, our friends, our colleagues, we're all doing the best that we can with what we know now. And so as a parent whose kids are in school, I am very grateful. But it is what was the decision that was best for our family. And we have been very, very happy with what our locality has been able to provide. And so I don't think any locality is going into this quickly or short-sighted. They are all doing the best research that they can do. And I think if anything, any of the positive of this is it has propelled a large amount of localities to look at other options, out of the box options that they can offer for students, because maybe in person isn't for everyone. And so I think that this virtual opportunity could be a long-term opportunity, which is a really exciting time for all students and families. So I'm going to peruse the chat box one more time, because I think a lot of people are just kind of giving their feedback and what they've experienced. Tracy or Joanna, could you please offer the number for the call center for the Virginia vaccination? Did you want to do that verbally? Do you mind doing it verbally, and I can type it in the chat as you say it?
Let me go ahead. I'll post it in the chat. As soon as we flip over, I'll post it in the chat.
Okay, sounds good.
Thank you.
Let's see. One person indicated that they have been doing 6 feet of separation since the beginning and have since September and have had no closures, and that's been in Greene County. This question, I think, Dr. Donowitz, would be for you. How do you feel about spacing between doses? CDC seems to allow for up to 6 weeks between the first dose and the second dose. Any research on effectiveness when second dose is delayed?
So not a ton of research, a little bit out there on this, but not a lot of great, large sample size studies. I think the important thing to realize is that your body, the idea of giving a second dose is your body has seen this thing and it's mounted an immune response. And then at some time later, you amplify that immune response by letting it see it again. And I don't think that there's, just in terms of what we know about vaccines, that you have to be as strict as saying, if you don't get it on the 21st day or the 28th day, the whole thing's going to fall apart and your body's not going to recognize it. Your body's most certainly going to recognize it a month out or 6 weeks out type thing. And so I do think that they're just, from an understanding how the immune system works, that there's some leeway here. You have to remember that a lot of what we're doing is extrapolating from other vaccines in terms of what we know, because we haven't had time to do all the studies on this. But if you miss your dose of a lot of vaccines, we don't revaccinate the whole series in you, right? Like, so if you didn't get your second Hep B shot on time, we just give it to you, or your second HPV. Lord knows that in that teenage group, we not everybody comes every year for a well child check, and so we don't always get you on time, and we just revaccinate you, or give you that second dose, and it works great. So I think 6 weeks is probably fine to get, if in between the two doses. Although, like I said, we don't have a ton of science proving that, but I'm not worried at all on that. If somebody asked me, is that safe to do? Do I think that's a problem? Absolutely fine.
Let's see. I guess, so in all of your kind of crystal ball, based on our current status, do you think the next school year will be back to a more normal person in learning environment? Predictions?
Well, I can see, this is Tracy. I can see we've made such great strides. I mean, I can see the light at the end of the tunnel. If you had said to me back in December of 2019, when this first came out, that we would have a vaccine within a year, I would have, I'm a child of the 50s, and I remember polio, and I mean, it took years of research. And I think what people have to remember, and it's going back to what you said, Carol, is this patience. We're not a patient people. We're very insta. We want things very quickly done. We want to know all the ins and outs of the vaccines, how are we going to need this every year? We just don't know all that stuff. That's just the reality. The fact that we are where we are, I think, is very encouraging. I think that as more people get vaccinated, I think we're going to feel better, as our confidence level is going to be increased. I look toward a more more normalcy as our confidence level in our school, as our rates start to drop. All this is a process. It's not going to happen overnight. People are still going to have to wear a mask. And I really want to emphasize that there's still a great gap in knowledge we're in it. We're people that are in healthcare, we're in it and around it, but there are still people that think, oh, I've got my vaccine, home free, don't need to wear a mask, I can go and do all the, and no, you still need to practice those mitigation strategies of wearing a mask, social distancing, washing your hands, all that kind of stuff. And so it's not a time to be complacent, but I do think that we're moving in the right direction, and we're all anxious to be able to be in person and be at conferences and see people. And I think I think the light's at the end of the tunnel. It's coming. So I'm very optimistic. I'm very optimistic.
Yeah, and I'll just echo that, Tracy. I have to say, in the world of infectious disease, there have been things that we didn't call an epidemic and we didn't call a pandemic, but they were scourges on our society. I mean, you look at people and who remember Haemophilus influenza and that bug, and there were so my mother is an infectious disease doctor, pediatric infectious disease. If you ask her, when she was training, there was a kid on the floor with Hib meningitis literally every day of the year. They were there all the time. And that was, we didn't talk about it like a pandemic, but it was there. And the way you get rid of infectious diseases that are scourging your society is vaccines. And so, I have seen one case of Hib meningitis my entire career in an unvaccinated child. And that's the change that a vaccine brought about. And polio, people don't know polio in this country anymore, and those type of things. And so vaccines are how you end this. And I think, people say to me, oh, this vaccine rollout has been terrible, blah, 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 nationwide. And I go, wait a minute, wait. It's the end of January and 11% of the US population has already been vaccinated. This is, I understand everybody wants Insta. Tracy's right on that. But this is going at an amazing pace in terms of getting vaccines in arms when you take a step back from it. The difference between January and February, I get is dire and people want this shot, but there is a light at the end of the tunnel. I agree with Tracy, and I think if we all do what her recommendation was and wear our masks and protect each other and get our shots, there's a light at the end of this tunnel, and we will see life as we knew it again, because that's the power of vaccines, and that's been proven time and time again.
And if there was ever a case of a great story for those people that are anti-vaccine, this is it. This really tells a powerful story, and I think it's something that we can use, whether we're talking about our children's immunizations, for school, whether we're talking about flu, whether we're talking about this. I think I agree. It's vaccinate, and this is the science. This is where we're at. And again, the CDC has provided a scientific paper, and most of the people that are probably on this webinar will be, I'll be sharing with them, and school nurses in general, Joanne and I, the information at the federal level from the Department of Education. They have phase 1 recommendations for schools that mesh really nicely with the CDC. And along with that paper that they've done, is really nice to see it kind of come together like that. So there'll be some great resources to guide schools as we move forward. And that's the important thing. We're moving forward, not backwards.
And one last question, and then we'll wrap it up for this session. Is there a possibility or a percentage that we could reach for vaccinations that would provide us with herd immunity?
So herd immunity is based on a couple of things to know that number. So it's based on the infectivity of the virus, how easily it infects. If I have the virus and I'm sitting next to somebody, what's the chance I transmit it to them? And those things are changing rapidly, right? So the UK variant is much more, it has a much higher infectivity rate than the previous virus. So that number is shifting. A lot of what Tony Fauci has been quoting and he says this, and if you ask him, is based on previous viruses and the most infective infectious viruses we know. So measles. So if you look at measles, you're looking at 85-90% is kind of a good number. Somewhere in that neighborhood. So there's no hard and fast number. But I think what we're going to see is as that 11% of the population, as we see that number go up, we're going to see a direct trend with the virus going down. And so I don't have a hard and fast for you of what herd, what's the target to get to. But, I think those of us who are sort of watching this, where I'd like to see 80%, I'd like to see 90%. I'd love to see 100% of Americans vaccinated for this, but I think we'll see the amount of circulating virus in the community drop rapidly as those chains of spread are interrupted by vaccinated individuals.
Let's see, I got one more last minute submission. When a patient presents with having received antibody therapy as treatment for COVID, when can this patient begin the vaccine, or when should this patient begin the vaccine series? Do you have any information on that?
I'd actually have to look that up.
Okay.
Joanna, do you know off the top of your head, or Tracy?
I would add, they would have to check with their healthcare provider on that one. Certainly, I don't really know the answer to that. Joanna, do you?
Yeah, I'm right there with you guys.
So
I
I
agree.
can
Double check with your healthcare.
Sorry, go ahead, Joanna. Sorry.
No worries. I said, I agree with Tracy. You want to go ahead and check with your healthcare provider.
Yeah, so there is an answer, and I just don't know it off the top of my head. When you get antibody therapy for other things, IVIG or something like that, it does delay your response to vaccines. And usually it's somewhere on the neighborhood of 6 months or longer. And I you have to forgive me. I know there is that recommendation out there. I have read it. I just can't pull it off the top of my head at the moment. Whoever that is who asked that question is a great question. If you want to email me, I can look that up for you.
And so it would be Jeffrey.Donowitz, as his name shows at the bottom of the screen, at vcuhealth.org. Now, don't share that with all your friends, just professional questions only.
But I am happy to answer anybody's questions offline, if that's helpful to folks.
All right. Well, we will allow Dr. Donowitz to get back to the rest of his day, and so greatly appreciate him helping us again. And hopefully at our next conference, we will be onward and upward to other topics. So we won't have to take him away from his research and patients again, but we love having him. So thank you, Dr. Donowitz. You're always so great.
Such a pleasure. Thank you so much.
Thank you.
We hope to invite him back in person.
There we go. There we go.
Yeah, thank you very much for your continuing support to help us learn and help us to be able to be more knowledgeable about COVID, and we appreciate that very much. Thank you.
No, thank you guys. The folks who are on this call today are the front lines and are such a source of information for the community at large. Anything I can ever do to support you as a group or individually, please reach out.
Thank you.